Okay, so this is part two. So I was telling you that bipolar disorder affects men and women equally. Women do have more suicide attempts, but with men, they use more lethal methods. And although bipolar disorder affects men and women equally, mixed and rapid cycling symptoms is more common among women. Women with bipolar 1 disorder have a younger age average of onset, and compared with men, women with bipolar disorder are more likely to experience comorbid um, disease like eating disorders. In the United States, the mean age at onset for bipolar is 22 years old, and slightly younger for women at about 21 and a half years old. And so for men, it's 23. So the mean average is 22. Women at about 21 and a half, and men about 23. And I think I'm seeing it much younger. I have several 18 to 20-year-old women right now who are classic bipolar 2. Okay, so let's talk about some risk factors. And I don't know, something was going on with this slide, so we're going to try this again. So let's see if we can get this slide to work. It still does not want to work. There we go. Okay, so let's talk about adversity in childhood. So it's those ACEs. Some risk factors would be like parental mental disease. So there's a lot of things going on in the family. There may be a lot of family conflict. Usually one of the parents may have something like drug use or a history of undiagnosed bipolar. Um, Things like cannabis and other substances can be associated with exacerbation of manic symptoms and the first onset of manic symptoms. And of course, genetic processes. So 90% hereditability in some twin studies of first degree relatives usually have about a 5 to 10% risk. Okay, so there are some co-occurring conditions. Usually, patients with bipolar disorder have about three or more co-occurring disorders, and some of the highest or most frequent would be like anxiety, alcohol use disorder, other substances that they may be using, and ADHD. Bipolar 1 is associated with borderline personality disorder, schizotypal, and other antisocial personality disorders. There are some sociocultural factors and patterns in families. And of course, the suicidal thoughts and ideations are definitely associated. There's a high risk of with patients with bipolar disorder. And some of the co-occurring and untreated medical conditions that are often overlooked would be like cardiovascular disease, metabolic disorders, autoimmune disorders, obstructive sleep apnea, epilepsy, migraines. So a lot of times, patients with bipolar disorder don't often seek treatment when they're depressed. They are really just taking care of themselves. They're not doing anything about the depression or their medical needs. So if we can get them feeling good and stable and not having all those mood swings, then we also need to refer them out, make sure they're seeing their primary care providers. So some of the screening tools, and this is by far not all of them, but the Young Mania Rating Scale is good for our children and adolescents. The mood disorder questionnaire, I use that one quite frequently. But another good one is the bipolar disorder, the stable. There's a stable resource toolkit. There are several tools that you can use. I use the mood disorder questionnaire because it's just pretty easy. So if they have 7 or more positive answers and it causes a moderate problem, it asks if there's anybody in the family that has bipolar and if they've ever been diagnosed. And what I normally do is I go over all of the positive responses with them to try and get a timetable of when these symptoms have been going on. But there's several that you can use. So we're going to move on to cyclotmic, and I probably said that wrong, my apologies, disorder, which that one, time is definitely essential for the diagnosis for that. So why is that? Well, the DSM-5 TR criteria says that for at least 2 years in adults, in at least 1 year in children and adolescents, there's numerous periods of hypomanic symptoms that do not meet criteria for a hypomanic episode. And there's numerous periods of depressive symptoms that don't meet the criteria for a major depressive episode. And I kid you not, I just saw a patient like this today. So I could not, I'm still working. And you guys know that you do not have to lock in to a diagnosis on the first visit, right? Because that may be difficult. And so I usually put a little statement about this being ongoing and the diagnosis is fluid, it is subject to change. Not in those words, but because you may not get a firm diagnosis on the first visit. So this patient that I saw today, I could not quite put it together. She probably is, her mother is bipolar and a substance, she has a history of substance use disorder. In this patient had several symptoms, but not quite meeting the criteria. She's got hypomanic episodes, but maybe lasting 3 days. I'm still working through it. So she probably meets the criteria for this one. So I did not do this diagnosis. I'm putting it on hold because of something that she has going on. I gave her an adjustment diagnosis, and I will continue to work through the symptoms for her when she comes back next week. So just remember, you are not locked in. You do not have, your feet are not to the fire to make a firm diagnosis on the first visit. During the 2-year period, the symptoms in criteria A have been present for at least half the time, and they haven't been without symptoms for more than 2 months at a time. So looking at that, nope, she does not meet the criteria for this. So I will still be working through a diagnosis for her. She's quite almost bipolar 2, but not quite bipolar 2. Criteria for a major depressive, manic, or hypomanic episode have never been met. So they've had this 2-year period. They haven't met the criteria for a major depressive disorder, manic, hypomanic episode. They haven't had any of those. But they have had symptoms present at least half the time, and they haven't been without symptoms for more than 2 months at a time. The symptoms in criteria A are not better explained by schizoaffective disorder, schizophrenia, schizophreniform disorder, delusional disorder, or other specified or unspecified schizophrenia spectrum, or another psychotic disorder. And they're not attributable to a physiologic effects of some kind of substance or some kind of medical condition. Okay, let's talk about pharmacologic treatment. So mood stabilizers. The first choice to treat bipolar. The first choice to treat bipolar disorders is mood stabilizers. Mood stabilizers like lithium, valproic acid, lamotrigine, carbamazepine. Those are all very good choices. antidepressants alone or with mood stabilizers appear to be less useful in children than adults. Moreover, the risk of switching or developing mood elevation in response to antidepressant medication is possible, but it's controversial. So, activation by SSRIs is more likely in children than adolescents and adults and may occur in about 10 to 20% of patients. So antidepressants would be like fluvoxamine, paroxetine, sertraline, bupropion. Those are used as pharmacologic treatment. And atypical antipsychotics like olanzapine or Zyprexa, aripiprazole, quetiapine, risperidone, Ziprazidone, and Latuda. So those are really good. So let's talk a little bit about what are some of the effects of these medications. So in adults, with the antipsychotics, QT prolongation due to antipsychotics is usually minimal when it's compared with a placebo, except for thiorizidine. Thiorizidine. But studies have shown that like aripiprazole decreased the QT interval, whereas risperidone, ziprasidone increased QT intervals. So prolongation is rare in children, but the risk is still clinically relevant. So even though it's rare, it's clinically relevant. So what are you going to do? You're going to screen them at baseline because although it's rare, there's, some kind of cardiac history in the family. If there's a person, if one of the patients has a history of having irregular heartbeat, some kind of unexplained tachycardia or shortness of breath, you remember we talked about assessment, so you're not bypassing this. You're asking these questions in your medical review of symptoms. If they have a personal history of dizziness or syncope, you'll definitely want to make sure that they have an ECG at baseline. So when you're prescribing antipsychotics for children and adolescents, choose an agent with the lowest likelihood of adverse effects on the body composition and metabolic status. So you're always going to choose a medication with the lowest likelihood of adverse effects for them, right? You're going to monitor these children for serum fasting blood glucose because, yes, metabolic syndrome, right? You're going to check their height and weight and get a BMI. You're also going to check children for movement disorders, just as you would with adults. So children can get movement disorders from antipsychotics. So you want to check all of this in your assessment. So we'll talk a little bit about a couple of the medications. Lithium. People hear lithium, and I swear it's like nobody wants to do lithium because of the monitoring of lithium. But lithium is a very good, tried and true medication, especially for your suicidal patients. Lithium is my go-to, and yes, I have to monitor the labs. It's very important, but lithium is a good medication to use. The mechanism of action is uncertain. Dosing is about 600 to 2400 milligrams, although I have never gotten up that high. Usually around 600, patients start getting a little not toxic, but their serum levels are a little bit too high, so I'm always bringing them back down. So I've never gotten up to 2400 on anybody. Maybe you guys have seen it in clinic. I have not, gotten that high, but I do use it quite often. Contraindications for it, you just educate patients on their salt and water content. It is not safe in pregnancy. Some of the more the adverse reaction, nausea, vomiting, diarrhea, I always tell them, hey, if you've got diarrhea and you are feeling bad, please let me know. And then I check a serum level on them, because a lot of times that could be one of the side effects, that they're starting to get a little bit toxic. Dyspepsia, acne, weight gain. Weight gain is for a lot of them. A lot of patients, you say weight gain, they don't want to take the medication. But when the benefits of the medication outweigh, so, these adverse reactions like just weight gain, it's safer to have them taking lithium than to worry about the weight gain. Sedation, they may start having some cognitive effects, some incoordination. It's very important when you're starting lithium to talk to the patient about the side effects. They may end up with some thyroid or kidney issues, so of course we're going to be monitoring them. And lithium toxicity is a medical emergency. So if you are going to use lithium, make sure that you are checking lithium levels. Don't ever get caught with a patient on lithium and you are not checking their lithium levels. Some neuro symptoms would be like slurred speech, tremors, cardiac changes. Yeah, these are all bad, right? So this is not your everyday, oh, if you just have some slurred speech, call me. No, slurred speech is a problem. Of course, the GI symptoms, kidney problems, late signs of toxicity, and this is way too late, so they should not get here. Impaired consciousness, seizures, or coma. Your patient should not get that far before you know anything. There's a very, very narrow therapeutic window, which is about 0.5 to 1.5. So if your patient is like 1.3, 1.2, you should still be checking them frequently because they're too close. I mean, they're tolerating it, they're telling you they're not having side effects, but you need to be checking. This is not a patient that you're going to say, oh, you're 1.3, I'm going to check you back in 6 months. Oh, no, no, no. You will be checking them frequently until that they're at a therapeutic level, and they're tolerating the medication, but you don't want them hanging out on the upper end. So you check every 2 to 6 months unless you suspect toxicity. So anytime they have any side effects, if there's any changes, get a level. Be safe, get a level. You should be checking their thyroid every 6 to 12 months, and these patients should have an EKG. So the mechanism of action for valproic acid or Depakote, which is an anticonvulsant, is really uncertain. The dosing for valproic acid is 750 to 3,000 milligrams. I start low and go slow for all of my medications. So I'm usually starting around 250 and working my way up. I've never had anybody at 3,000 milligrams. So, yeah, I usually start low and go slow. I don't get that high. As soon as they're at their therapeutic, that's where I stop. There is a boxed warning for valproic acid for increased risk of pancreatitis and liver failure. Some of the adverse reactions include hair loss, weight gain, sedation. So, of course, if sedation is one of the adverse reactions, you tell your patient start the medication at night. Liver and pancreatic effects, which I just talked about. Females may experience amenorrhea, polycystic ovaries. They may have the hyperandrogenism, insulin resistance, of course, obesity with the weight gain, insulin resistance in their childbearing years. There are fetal toxicities of neural tube defects. So this is a medication you really do not want to prescribe to a female in her childbearing years. So if you can pick anything else and avoid valproic acid because of the neural tube defects. Also, one of the questions you're asking your patients when you're doing your assessment, especially females in the childbearing years, is when is your last menstrual period, and document it. If it's not in the EHR, if it's not created that way, it's a question you want to make sure you're asking and document it somewhere. Some other adverse reaction would be thrombocytopenia, leukopenia, and drug interactions. So like what kind of drug interactions? Well, it doubles concentrations of lamotrigine. So if your patient's on one, you definitely have to watch because the valproic acid is going to double that concentration. It causes increased levels in diazepam, Tegretol or carbamazepine, amitriptyline, nortriptyline, and phenobarbital. So it's got some pretty nasty drug interactions. There's decreased levels of sodium with fluoxetine, amitriptyline, guanfacine. So there's those medications decrease the levels of your valproic acid. So that all comes into that very good psych eval, right? So you're going to know what medications your patient is on. Then you know the adverse reactions and drug interactions of the medications so you're able to prescribe safely. And I'm sure you guys got this in Psychopharm. Before you start treatment of valproic acid, you should get a CMP, LFTs, a CBC, which includes white blood cells, platelets, and of course, a urine pregnancy test. During treatment, you're going to monitor their LFTs and their CBC at least a month after you start it. And then you'll do it about every 6 months, and then you'll back to every 12 months. And then once they've been on it and they're stable, mainly males, because we want to avoid the childbearing females, then you'll do it about every other year or so. If their LFTs are abnormal, monitor them for about 1 to 2 weeks. And then if they're stable, you can go to every 3 months. If their LFTs are more than 3 times normal, you're going to reduce the dose and then discontinue the medication. So the serum plasma level for this is about 50 to 125, depending on the lab. So once they're stable, every 6 months, and then annually, and then you can back it down even further than that. Carbamazepine, also known as Tegretol, is an anticonvulsant. The mechanism of action for this one is blocking voltage-sensitive sodium channels, or the VSSC, at a site within the channel itself. You do not have to know that for your exam. Dosing is about 600 to 1,200 milligrams. Some of the contraindications are those with CYP34A. It decreases concentrations of oral contraceptives. So if you are prescribing this, your patients need to know they probably need to use another form of birth control. So that is why it's so important to be able to educate your patient and understand these medications. There is that 2-week washout with MAOIs, either before or after. You have to have the 2-week washout. And you want to alert your patient to not drinking grapefruit juice when they're taking carbamazepine. There is a risk of bone marrow suppression, induction of the cytochrome P450, sedation, fetal toxicity. So this also has neural tube defects. So you're going to avoid prescribing to women in their childbearing years if you have to, because the benefits outweigh the risks. Make sure that you have documented clearly about the risks of neurotube defects. For drug interactions, with valproic acid, you're going to need to decrease the Tegretol dose. So if they're taking valproic acid, you have to decrease the Tegretol dose. Initial monitoring of blood counts, you're going to do liver function tests, hepatic, if somebody has like a hepatic disease, then they're going to get about 1/3 to half of the normal dose. And you're also going to get an EKG. Lamotrigine, Lamictal. I like Lamictal. You may run across a lot of providers that don't like Lamictal. It's an anticonvulsant as well. The mechanism of action is binding to the open channel site of the sodium channel, the VSSCs, reduces the release of excitatory neurotransmitter glutamate. Dosing is about 100 to 200 milligrams is where they reach their therapeutic level, but you start this one off really low over several weeks. So it's normally 25 milligrams for 2 weeks, and then they go up to 50 milligrams for 2 weeks, and then 75 milligrams for 2 weeks. And then after that, you can get them on 100 milligrams, and they're probably going to stay about right there. Some can stay at lower doses longer. So if they can, and the medication is working, I like to leave patients at the lowest possible dose so I have room to go. So I don't rush the medications. I do the 25 milligrams over the 2 weeks and then the 50 milligrams over 2 weeks. So now we've gotten to a month, and then I can assess and see how they're doing at that 4 week period and determine if I want to go up to the 75 milligrams or not. So it's a very slow titration. It is not approved for children younger than 16. So this is not one that I use on children and adolescents. They have to be very medication compliant with this one, because if they miss 4 or more days, then they have to start this all over again. So they have to be compliant. And I make sure to let them know, if you miss 4 days, we're starting all over again. One of the adverse reactions is a rash. You gotta tell them to monitor for a rash. There's a rare incidence of Stevens-Johnson syndrome, or TENS, which is the toxic epidermal necrolysis. So they need to be aware, if they get this rash, they need to stop this medication. I did have a young patient recently who thought she had a rash, and of course she came in the next day and she said, oh, the rash is gone. So she really didn't have a rash, but they're checking their skin to see if they get a rash. Valproic acid increases the serum lamotrigine levels. I think we just talked about that. Zoloft, sertraline, increases serum lamotrigine levels. So again, if they get the rash, tell them to stop the medication immediately and let you know. I've sent a patient to urgent care before because she thought she had a rash. I don't do after hours, and it was nothing. But it's better to be safe than to be sorry. Okay, so oxcarbenzapine is another anticonvulsant, which is triliptal. The mechanism of action is binds to open sodium channels. The dosing is about 600 to 1200 milligrams, but it can cause sedation and nausea. And I'm actually tapering a patient off of this right now because of the sedative effects. She's just not doing well, so we're going to take her off of this one. It does interact with phenobarbital. It interacts with alcohol and oral contraceptives. So again, you need to tell them they need to use 2 forms of oral contraceptives. Doesn't require any blood monitoring, so I like it, but it can cause hyponatremia. So I do like oxcarbenzapine. However, the sedative or sedative effects, some patients just can't tolerate it, so you'll need to take them off. The 3 medications, which is OFC, quetiapine, and loricidone, have been FDA approved for bipolar depression in adults. OFC is the olanzapine fluoxetine combination. Quetiapine has not been proven to be any better than placebo in youth ages 10 to 14. And antidepressants alone or with mood stabilizers appear to be less useful in children than adults. So having them on the mood stabilizer and the antidepressant is not going to give you a better benefit. So, and again, the risk of switching or developing mood elevation in response to antidepressants, we kind of talked about that before, is possible. So that activation by SSRIs is more likely in children and adolescents than adults. So that was just a repeat of some information for you. Okay, let's talk about atypical antipsychotics again. Um, we'll go over this just a little bit more in detail. The mechanism of action for atypical antipsychotics, they primarily work by modulating neurotransmitter systems in the brain. So they typically block dopamine receptors and serotonin receptors. And the dual action helps to alleviate manic symptoms while minimizing those EPS side effects commonly associated with those older antipsychotic medications. The specific mechanism may vary among different atypical antipsychotics, which is why it contributes to their different clinical effects. The efficacy in treating bipolar mania research has demonstrated that several atypical antipsychotics are effective in treating acute manic episodes associated with bipolar disorder. So medications like olanzapine, quetiapine, risperidone, aripiprazole, they've all shown that they have significant efficacy in reducing manic symptoms. And that's through randomized controlled trials, which, as you guys know, that's the gold standard. Olanzapine is often used as first-line treatment due to its rapid onset of action. Quetiapine is effective for both mania, acute mania, and maintenance therapy. I really like quetiapine, except for the weight gain that's associated with quetiapine. Also, metabolic syndrome, sedation, dizziness, and EPS. Risperidone is frequently prescribed for its effectiveness and tolerability. Aripiprazole is noted for its unique mechanism of action that may lead to fewer side effects. So aripiprazole is really a good one to choose, and I do use that one often. So when we're talking about the safety and side effects with atypical antipsychotics, they're generally well tolerated when compared to those older antipsychotics. But they still can have various side effects that, we need to alert our patients to. So, and we have to monitor them closely when they are on antipsychotics. So if your patient is not bringing you labs from their PCP, you need to be monitoring their labs. So we're going to monitor them for weight gain, for metabolic syndrome, increase in their blood sugar, which is metabolic syndrome, right? And we're going to watch their cholesterol levels. I have a patient, she's in her 60s, and I am battling back and forth about the metabolic, high cholesterol. So I have gone down as much as I'm comfortable on her risperidone because she has been stable for so long. And now I'm working with the primary for them to start going up on her cholesterol meds because I've gone as low as I can go without having her go into some manic episode. So they've got to figure out how to get this lower. Sedation, dizziness, of course, the extrapyramidal symptoms, although those are less common with the atypical antipsychotics, but they can still happen. With long-term use, you definitely need to be monitoring their parameters to prevent any complications like diabetes or cardiovascular issues. Have I seen this happen? Yes, I have seen where a patient has had to be prescribed insulin because of a provider not monitoring their lab work, and the patient's A1C ended up being like 12, 13, 14, something like that. They had been on quetiapine for over a year, and the previous provider had not checked their labs. When you consider atypical antipsychotics, consider individual patient factors like age, comorbid conditions, previous medication responses. Also, start at the lowest dose and then titrate based on the response and tolerability. And I know I'm probably like a broken record saying that over and over. Start low, go slow. Sometimes you may have to combine an atypical antipsychotic with a mood stabilizer like lithium or valproate because that can enhance treatment efficacy. Educate the patients about potential side effects and how it's vital for them to adhere to the medication schedule and managing expectations regarding treatment outcomes. And remember, you have to get informed consent. So tell them all the ins and outs and then get informed consent. Okay, so we'll talk a little bit about, oh, is it going backwards again? Every time I pause it, it goes backwards.